Good afternoon. It is my pleasure to welcome each and every one of you to the 2021 IPHAM Population Health Forum for the very first time in a fully virtual webinar format. I'm Ron Ackerman, Senior Associate Dean for Public Health at Northwestern University, Feinberg School of Medicine, and Director for the Institute for Public Health and Medicine. Today, we will spend the next 90 minutes in an engaging dialogue with Dr. Allison Arwady, Commissioner of the Chicago Department of Public Health. Our dialogue will center on the theme of public health triumphs and challenges amidst a pandemic, past, present, and future, and the role of academic partners. Joining me in this conversation with Dr. Arwady are IPHAM members, Dr. Jolene Girardin, who is an expert in the use of infectious disease modeling to inform public and population health policy, and Griselle Robles-Schrader, who is an expert in community and stakeholder engagement in both research and in student educational initiatives. Dr. Arwady is a board-certified internal medicine and pediatric physician who has served as commissioner for the Chicago Department of Public Health since January 2020. Prior to her appointment as commissioner, she served for 5 years as a chief medical officer at the Chicago Department of Public Health, where she oversaw the disease control, environmental health, emergency preparedness, and behavioral health divisions. Prior to joining CDPH, in 2015, she worked as a CDC Epidemic Intelligence Service officer, where she was based at the Illinois Department of Public Health to respond to disease outbreaks throughout our state, as well as international work focused on threats such as Ebola and the Middle East respiratory syndrome. Dr. Arwady has a bachelor's degree from Harvard University, a master's degree in public health from Columbia University, and completed medical school and clinical training at Yale University. We will begin today's forum by asking Dr. Arwady to make a few opening remarks about the Chicago Health Department's ongoing initiatives to address the COVID-19 pandemic. After these initial remarks, we will open the floor to a question and answer format. Because of the large group assembled here today, I will facilitate this dialogue by channeling questions that are posted by you, the audience, in the Q&A area of the Zoom platform. Please enter your questions at any time during the presentation using the Q&A function at the bottom of your Zoom screen. Please do not use the chat function, as we will not be monitoring the chat for your questions. So, without further ado, it is my profound pleasure to introduce to you today Dr. Allison Arwady. Allison?
Thank you so much, Dr. Ackerman, and thank you to the Institute for Public Health and Medicine, to Northwestern, and to all of you for joining. I have long enjoyed this event. I've been there in person in the past, and really appreciate everybody tuning in and all of the ways that we've adjusted our work in public health and medicine and in making Chicago better to this virtual environment. And I'm really looking forward to the conversation today. I want to start just by saying I want this to be a very open conversation. I think it's an opportunity to think about what has gone well in Chicago and some of the lessons that we've learned. Also very interested, as you'll hear, about how we are thinking about taking what we've learned from COVID and, to be honest, the increased platform and awareness that public health has as a result of COVID. How do we build on that for the future? How do we really bring additional attention, to the fact that many of us in population medicine and public health already know that it takes an outbreak to really highlight the cracks in our society, right? The places and the ways in which we do not support people equally. We have a lot of inequities at baseline. Those already show up as health inequities within Chicago, just as they do across the country and around the world. And for those who may not be aware, the Chicago Department of Public Health, working with many folks across Chicago, I'm sure a lot of you on the call were probably part of this, we had put together what was called Healthy Chicago 2025. That's our 5-year strategic plan. It was supposed to launch in March of 2020. So if you think back to what was happening in March of 2020, it was not a moment that the Chicago Department of Public Health had a lot of bandwidth to launch that Healthy Chicago 2025 initiative. We did later launch it in September when things were a little calmer from COVID. But what was so striking to me was we did not have to change one word of that plan, where we were thinking about what do we as a city need to do to really grow public health and think about working on, racial and ethnic inequities within Chicago. And so just to sort of set this up, if you're not familiar, I'd encourage you to Google Healthy Chicago 2025. You can download the document, but it really highlights the fact that here in Chicago, we have a very large life expectancy gap that is racially and ethnically driven. It's almost a 9-year gap before COVID between Black Chicagoans and white Chicagoans, for example. And it looks at the 5 main drivers of that gap in terms of the proximal causes, what shows up on the death certificate, whether that's chronic diseases, which are the biggest part of that, whether that's homicide, infant mortality, HIV, or other infectious diseases, which is why we didn't have to change a word of it because of COVID, or finally opioid overdose. Talks about what as a city we should do to work on these issues, but then really highlights a lot of the root causes, things like housing access, food access, access to health care, but also access to the social systems that help really promote health. And so when I think back on COVID, January 2020 is when I formally became the commissioner, and 4 days later is when we activated for COVID here at the health department. I was familiar, certainly, with CDPH and had been working in the emergency preparedness and the infectious disease and the outbreak space. So in some ways, this response was something that I personally, and really the department, had trained for and prepared for years and years and years. But we know that really outside of public health, there was perhaps not this level of awareness or preparedness. And so when I think back first on something that I think was a success, but also sort of a challenge going forward, is that we really were here in Chicago, it turned out, from a preparedness standpoint, in a remarkably better place than most other cities were. We had, millions of supplies stockpiled right here in Chicago, things like masks and gloves, and we had ventilators, and we had a strong healthcare coalition that had already been built, that was used to collaborating around emergencies, that was used to practicing, and could sort of go on from there. We'd done a lot of planning. We had done an exercise just the prior year where we had pulled together federal, local, and state partners to think about the possibility of a very large, we had exercised it as a flu pandemic, but we had actually thought through, what if the schools all had to close down and you had to figure out how to make sure people were getting fed, right? And so I think the fact that there had been here quite serious focus on that public health preparedness role paid off in spades. And where I think ahead, all of us, I think, who are interested in public health broadly, it's about what does it mean to invest in that preparedness outside of an emergency, not just the funding sort of for COVID response, but really making sure that we've got the baselines in place. I think a second area that I am really proud of, where I think we are still learning and very much growing, but I think has been a space that we have put our stake in the ground and gotten a lot of feedback and a lot of conversation around, is really putting equity at the center of a response. And we have worked to do that really from the beginning of COVID. Mayor Lightfoot, you may recall, just in the first few weeks of the COVID response, when we started seeing how much more dramatically COVID was impacting African Americans initially, and then a little later, Latinx population. We launched what we called the Racial Equity Rapid Response Team, really without a very broad sense of even what that would be, but recognizing this need to talk very explicitly about race and about ethnicity and about access and about the underlying root causes that put different depending on where you live in this city, you have very different opportunities, putting that central and really bringing in community voices in ways that are not just to comment on existing plans, but to help create plans, to help push back, to help say this is working, this isn't. And I think there's been a lot of very, very healthy tension in this space. And I really mean that, where there has been a level of community engagement with healthcare providers, community-based organizations, faith leaders, just Chicagoans in general, plus people in the academic community, people who, spend their lives really thinking about public health. Everybody has had an opinion about COVID. And I think that has been very healthy in terms of really pushing, speaking at a personal level at the health department, where are we going? What do these resources look like? And so when it came time for vaccine rollout, we were able to take a lot of the lessons and some of the things that had already been set up through Protect Chicago, for example, a data-driven way of saying, where are we going to put our resources? And with Protect Chicago Plus, some of you may recall, we, again, working with many partners, developed a very data-driven index that was not just about where had COVID landed the hardest, although that was part of it. It was also saying, what do we know may be barriers for vaccine access for Chicagoans? So it's pulling together data that, academics have helped collect in some cases, or that the health department has done real work in advance. So we know where in Chicago people don't have access to primary care. We know where they have barriers, to other, to technology, for example. We know where there are a lot of essential workers. We know, and we use some data related to anonymous cell phone tracking. So we were able to look at movement around Chicago and know where people were unable to stay home. Putting all of these factors together, and then obviously where we saw a lot of chronic disease, and we know that people are more likely to have those severe outcomes, said, we're going to rank all 77 community areas in Chicago, and those first 15, that's where our focus is going to be. And really saying, if you are in one of these community areas, there is vaccine reserved for you. It is open to you at different ages than it would be broadly across the city, and that we're going to do the work then of saying no to a lot of other settings to really allow us to prioritize those areas. I felt like this was an opportunity for us to really put our money where our mouth was when it came to saying, from an equity perspective, it's not just enough to say we're going to work across the whole city and try to lower barriers. It's like where a resource is very scarce, saying this resource needs to be dedicated to this area, and then work with so many community partners. And I can't emphasize enough how critical the community partners and the and the medical providers and this whole space has been. There is zero chance that Chicago would be anywhere near where we are today if not for the hundreds and hundreds of organizations that have stepped up across Chicago to say, I want to solve this in my neighborhood. I want to think with the health department about how to do this differently. And so we're sitting here from a vaccine perspective, still with a long way to go. We've got about 46% or so of Chicagoans have gotten that first dose, but that is the highest among any of the large US cities. So we've been doing well from an efficiency standpoint. And then from an equity standpoint, we definitely still have a long way to go. We're at about 35, 36% of Latinx Chicagoans have gotten a first dose of vaccine. About 30% of Black Chicagoans have gotten a first dose of vaccine, even though we know those are the communities that have been hit the hardest by COVID. So very long way to go. But again, where we look across those largest US cities, the top 8, 9 cities, we are doing better than any of those cities in terms of Latinx coverage and Black coverage, which tells you that the country has a very, very long way to go in terms of thinking about how are we set up? Why does this look this way? And so I think this focus on equity, along with real, honest community engagement and investment, and then this cross-sector collaboration has been absolutely critical to anything that has gone well here, and anything where we've really changed operations and thought about what these look like going forward. There's a whole list of other things that I could name for the sake of time, though. That is where I would probably highlight, I think, some of the areas that I've been particularly proud of, just to kind of tick them off so you here. I do think we've done a lot of progress on what we do with data, and I'm guessing that this group may have some interest in this, so we'll talk about it some more. When we started, and where we think about transitioning to challenges a little bit here, when we started COVID, the health department was quite used to the typical epidemiologic approach of putting out an annual report, right, on HIV, or a monthly report maybe on opioid overdoses. But for COVID, it became essential that we were really looking at things on a daily basis, and then not just looking at them, but using that almost real-time access to make decisions about where do we direct resources, where do we direct testing resources, where do we direct outbreak investigation resources, where do we direct education, where do we direct vaccine. So this real data for use became something that had always been a goal of the health department, but because of how quickly this needed to happen, became something that really is a reality for us in a way that it never has been. Also, where I think about challenges at the beginning, these data sets have gotten so big that the health department, and actually the city of Chicago, had always only ever used servers, if you know what I mean, like in terms of we're running very large data sets using large programs, and these data sets were getting so big because we were updating the entire data set every day. It was taking the epidemiologists 6, 8, 9 hours literally just to sort of run the day's data. And we had millions of eyes on our data. That's the other thing. Like typically, right, we're happy to get tens of thousands of people looking at a dashboard. We would be very happy with typically. Millions of people have looked at, and many continue to look at these dashboards. And so important to have this available for transparency. And these are the numbers that are being used to make big economic decisions related to reopening, making sure that data was up to date, absolutely accurate, transparent, available to the public. Really wanted to make sure you could slice and dice it by geography, by race, ethnicity, by age, by zip code, all the different ways. And so we moved, and this was with a lot of support from a lot of academic partners. Rush in particular really stepped up here in terms of helping us move into the cloud. We had never done anything in the cloud environment. And the ability to start modernizing some of our data sets, and that's just one example, means that now those epidemiologists can run those same reports, 5-10 minutes, and then can actually spend their time doing more of the analysis as opposed to just that data crunching. There's also been amazing work related to thinking about data in new ways. I know we're going to hear some more about modeling, but boy, like what an interesting year this has been for thinking about how to use data, how to use it forward, in a forward projection way. And we have worked with multiple modelers to really make decisions. And that is not something that we had historically done very much of here. We'd looked at models. We certainly looked at predictive modeling to inform our operations, but in terms of these like big decisions, that was new for us and exciting. I also think where sort of a challenge and then something that we've worked to kind of rise, the public health department does not have its own laboratory, and where you're thinking about the need for genomic surveillance, variants that are arising, real sort of very technical work on that. There's a lot of need for partnership and support and interesting work there. And so, for example, with some of the federal funding, we were able to launch this regional innovative public health laboratory, which is drawing on academic resources across Chicago. And we've hired some real expertise. We're going to have some capacity internally to do more of the kind of genomic analysis that we've always wanted to do. But all of this is being done, in partnership with academic partners, and I think it's critical. Where I really look at other challenges, one is just frankly, and I don't think this is going to come to a surprise to anybody on the call, public health has just not been staffed adequately across this country. It has not been resourced adequately for probably 20 years plus. And I was talking to one of my colleagues the other day, and they were saying, now that there is all of this funding available, it's very exciting, but it also feels like rain falling on very parched earth. And in terms of our recognition that we needed to launch this very large response on a department that is not administratively set up to handle this amount of work, quickly. McCormick Place, when we turned that into an alternate care facility, was amazing to me, partly because it was it happened so quickly, but mostly because that was the government getting something done really remarkably quickly, again, with so many partners. But recognizing that in an emergency, you need to be able to hire and contract and get this administrative work done extremely quickly. And that is just not how a lot of processes in government, but I would say probably more broadly, are set up. And so we're still thinking a lot about how to work on administrative support there. And thinking about how to grow the public health workforce in a way that is sustainable, that is community driven, and that has the opportunity to really work on things beyond COVID. One other area that I think has been, that we've not done as much here, that I think would be a great place for further academic collaboration, is that I think, we've been this interesting laboratory of trying new ways of doing things, but we've had almost no capacity to evaluate or honestly to write up and share our learnings with the field, right? Like, we're so busy doing this that multiple times throughout the pandemic, I thought, wow, that was this really interesting way that we thought about doing this. We should write that up. We should share this. But we just, when you're in the middle of doing it and being very stretched, I think we've not done as much of that evaluative work, and especially the work of getting that then into the public health and scientific literature. And I would love this to be a space where we're thinking about kind of further collaboration with academic partners around a lot of that work. And then where I'm thinking ahead and sort of what comes after COVID. So we are absolutely here at the health department trying to use things that we have built in COVID to extend beyond COVID. And I'll give you just a couple very short examples and then I'll be done. So there have been all these indirect impacts of COVID. And we, especially where we're thinking about our Healthy Chicago 2025 goals, we've been wanting to say, how can some of what we're doing on COVID, not just as a health department, but as the city, actually support these larger goals. So I'm going to take one example quickly, which is some of the work in the housing space. So very early, like in January, before most of the world was paying attention to COVID, we were scrambling because we needed to be screening travelers from China. And if they had particular risk factors, we were supposed to be quarantining them. And we did not have a good way to do that here in Chicago. And right from the beginning, dozens and dozens of people started to get involved into this thing of, how do you house people? Like, how do you house people that have particular public health needs? And then this transitioned, of course, once it became a wider outbreak, into, oh boy, like, all of these people who are unstably housed are also extraordinarily high risk for COVID for all of the root cause reasons that we know. And we need to decompress a lot of the shelters. And so we started working with the Department of Family and Support Services, but also all of the shelter providers. And it was about, how can we quickly work to move people and get folks into other spaces to try to protect from COVID? And how do we get testing in? And how do we get other pieces in? And then from that, it became, all right, well, why don't we actually, before we wait for these folks to get COVID and need to isolate them, let's think about moving very high risk folks who are in the shelter system into hotels, right? Like this actual supportive living concept where there are people, and this was again in partnership with multiple medical providers and others. We were providing the funding and some of the structure, but this was again sort of a larger city effort. But saying, we're going to house people and we're going to figure out, what are the supports that you're needing? Can we help stabilize some of your chronic issues, behavioral health issues, and really protect you from COVID while we work on sort of helping stabilize other factors in your life? And then it was like, well, we have all these people in these hotels. Let's work on transitioning them into permanent supportive housing. And how do we do that quickly? And so we have used this transition throughout COVID to say, let's use kind of the emergency that COVID has given us to say, throughout all of these spaces, how do we work together across silos, right? Like the space for people experiencing homelessness has a lot of players in it who are all very committed to doing good work, but sometimes it's not as coordinated as it could be. And to say, here's our goal, here's an opportunity, here's some funding available because of COVID to try new ways to do this. And so, for example, we not only did testing, but we said, let's get primary care into the shelters, right? Something we'd wanted to do forever. Able to use some COVID funding, set up some contracts. Our shelters now have primary care available in them. Again, thanks to providers across Chicago. We've done that. And with doing that, we've been able to do more outreach to people experiencing homelessness who are, riders on the trains. But with the primary care in place, we've then in turn seen fewer 911, fewer police needing to go to shelters. We've seen fewer ambulances needing to go to shelters. We've seen more stabilization, and this recognition that where you can take something you had to develop in a crisis and use it to build a stronger infrastructure is absolutely what we're wanting to do. And so as we look ahead, the health department remains very committed to this work of supporting community members. When we started contact tracing here, most cities and states hired a call center, for example, to do contact tracing. And we instead worked, we put out a request for proposals, and we worked with the Chicago Cook Workforce Partnership, who in turn 31 community-based organizations on the west and south sides of Chicago to hire 600 people who did not need public health expertise. Earn as you learn, get those folks in. They started as contact tracers. They're now resource coordinators. They're doing some of this Prometoris vaccine outreach work. They're making appointments for vaccine. And our goal is that a program like this, these are people who become community health workers and sort of plug in. So thinking about the pipeline also, I know obviously the school is here, and really wanting to have good diversity in our pipeline. What does it mean to support people, especially people who know and live in a lot of the communities that are most impacted by whatever public health issue you're working on, I think is really critical. And raising those voices is important, but so is having representation, I think, within the health department within leadership. And so I also, challenge public health schools and anybody working on public health to really think about that pipeline, students, and supporting diversity of all kinds as you're working on that. And so I think with that, I will sum up, and I look forward to additional conversation. I think, there's nothing I would have rather been doing for the last year and a half. It's been an absolutely crazy year, but I couldn't be more proud of my team. And I really couldn't be more proud of Chicago. We have been national leaders in a number of spaces here in terms of some of the collaborative and innovative work that we've done. And I hope that we together will build on this and really work on some of the longer standing public health platforms and use this, we've had this opportunity to raise our public health voice. Let's use that. Let's push towards policy that we want. Let's build structures that can last. And let's work on the goals, like Healthy Chicago 2025, even as we start to put COVID more behind us. Thanks.
Thank you so much, Allison. Firstly, I just want to say thank you for your leadership as commissioner. It's remarkable to take the post in January and 4 days later be told that we're focusing on a pandemic and not knowing what you're getting into, but definitely a baptism by fire sort of scenario. You brought up a lot of really interesting areas there and gave examples of successes, and I think what you described early on as cracks in the system. And I tend to think of the public health system and our response to the pandemic as a very complex system where the health department, like CDPH, is a steward of limited public resources to provide leadership and strategy, but it involves so many moving parts and pieces. And it's great to hear you talk about the engagement of community partners and academic and a variety of other examples of coordination with agencies to make successes in areas that are so critical. One area I thought that might be helpful to focus on just a bit is the comment you made related to current statistics around vaccine penetration, and because it gives a stark contrast between goals for population health, which is get as many people vaccinated as quickly as possible, and goals for health equity, and how those can head in slightly different directions. And we've made great gains at a city level in penetration of vaccine distribution from the early beginnings, when we were being criticized, I think, as a city of not getting people vaccinated quickly enough. And now I think you mentioned 46%. But you mentioned in some of, as we think about Black and brown communities throughout the city, rates more in the 30s. And if we just think of that as a grade of how well we're doing at a system level, and again, I'm not pointing just to your department, but what does that speak, with respect, you talked about workforce, you talked about data systems, you talked about a variety of things that maybe weren't in place. Some of them moved to develop very quickly and had advantages. What are the prevailing challenges, or even more specifically, infrastructure or resource deficiencies that prevent us from being more successful in reaching a better goal around equity? Even just the example of, it's clear that those same communities have inequities in the burden of disease and a lot of other social and structural determinants that underlie the burden of COVID. But just with respect to vaccination,
sure.
What are the keys there? Like in the world of limited resources, what do you need most in infrastructure and in resources that would help to address those challenges?
Sure. So I think that there's a few things there. And I do, to this potential tension between efficiency and equity, we have tried to sort of reject that as sort of a false choice here at CDPH. I think it is one that is often held up. And we worked very hard here to first make sure you could hit those efficiency targets, right? Because I think when you do have a vaccine, or you have anything that is so limited, you first have to make sure that you've got the systems in place to get that out, as quickly as you can. So making sure, for example, every single week since COVID vaccine has launched here in Chicago, 95% or more of the vaccine allocated to Chicago has gone out the door. And every single week since we've launched, 85% or more has been in arms and reported within a week. And those are both metrics that are well exceeding any national, and most state metrics. And we felt like getting those in place actually is critical. But getting those in place at the expense of equity was not something that we were particularly interested in. And so, it's been interesting, and I would encourage folks, if you're interested, chi.gov/COVID- is where our main dashboard is, and you can look at geography, and then chi.gov/COVID- COVID- is our dashboard, COVID-Vax is our vaccine, but we're going to be combining them shortly. And you can see that during some of the periods, like particularly in phase 1B, if people remember, where there was quite limited vaccine and we had some more ability to direct, we were making very, very good progress from an equity standpoint. And then as vaccine has been very widely available, you lose some ground on that, right? We set a goal that the majority of our vaccine every week would go to Black and Latinx Chicagoans, and we've hit that almost every week, except for when there's been a major expansion of availability, and then you have folks, for a week or two chime in. But I think number one, we don't have the same healthcare infrastructure across this whole city, and where you're thinking about vaccination, and the best place to get vaccinated is with your primary care provider, right? Someone who ideally you have a relationship with, who knows your medical history, where there's some trust there, where you can recommend vaccine. But you think about all the things that need to be in place for someone to have a primary care provider. And that includes there being physical locations near where you live. That includes you having a job that allows you to go and see a provider during the hour that the provider is open. That includes you either having insurance or being aware that there are federally qualified health centers and other places where you can access that without insurance. And that includes it being a priority when there may be many, many other priorities, where we're thinking about spaces in Chicago where food access and neighborhood safety and a lot of these other structural causes really have such an impact that something like getting a vaccine may not be top of mind. And so where I think we are right now is that there are a lot of people who have not said, no, I don't want to get a vaccine, but it's just not on the top of my list. Are there things, we're working to try to say, how can we, especially in areas where there's not as many pharmacies, right? There's not as many providers. This infrastructure isn't there. What can you do to try to fill some of that in? In a long-term way, of course, you'd like to build that sort of infrastructure and really use the opportunity that it's not just about getting the vaccine. It's about, if we're contacting you to get a vaccine, can we also connect you to primary care? Can we also connect you to some of those other resources? So I think that's some of it. I think who is discussing the vaccine is also really important. Trusted community voices are critical here. I know that I am not the best spokesperson. I am from the government. I am a white woman. I may have been talking about other things people may not agree with. In a lot of spaces, I'm not the best one to carry that message, and I know that. And the work that we're trying to do to build sort of vaccine ambassadors within communities, people who are already trusted and part of those communities, support that work appropriately, fund it appropriately, train folks to carry that message and have that conversation, I think is also going to be really critical. And I think there's just a long history of mistrust and disinvestment that we are working against. And so being honest about that and saying, this is a fact, right? This is part of our history here in Chicago, and we are trying to do better. And let's try to do better together. What does that look like? How can we fund some of this? And so as we're looking ahead, we're going to be funding these health equity zones across the whole city. And there's going to be lead organizations in each of the areas, and the whole city is in one of the zones. And then there's going to be funding for community-based organizations within every community area who are kind of coordinated in these regions. And the idea is that, yes, some of this starts with vaccine outreach this summer, but then we build on that as we get additional funding in for CDC, for other issues, et cetera, this network of community outreach and community-based organizations partnered with the very strong federally qualified health center and other provider networks together are something where we can set some infrastructure and fund so that no matter what is coming, we're not starting from scratch. And so I think one of the reasons, frankly, where I think we've seen our Latinx coverage for vaccines is not where I want it to be, right? It's 36%. It's not where I want it to be. But there are cities in this country where Latinx coverage is like 12%, 14%. And the reason that we are where we are, I think, is that there was such an amazing amount of community sort of engagement and coordination around this. And funding that in a more long-term way and helping sort of support that growth, not get in the way of it, but try to help make sure things are rowing together. Doing that in all of our communities across Chicago, I think builds infrastructure, builds jobs, doesn't assume people will just do this out of the goodness of their heart, and says, let's create a real structure of getting information from trusted messengers, getting resources where they need to go, and let's not think of this as something ending with vaccine.
Yeah, that's really great. It's refreshing to hear you talk about establishing systems to work with communities in ways that are sustainable and not knowing what the next challenge will be in this pandemic or whether we'll face another pandemic challenge in the foreseeable future. We want to do better. And so establishing sustainable systems seems so critical to that. Yep. You talked about some of the evolution of data systems and the ability to manage, collect, manage, and make decisions from data so much more quickly than in the past. And that was catalyzed by the pandemic. And as I thought about that and the challenge of needing different decisions and solutions in different communities and with different populations, it creates that challenge where you need to support the systems that'll, it's the mantra of nothing about us without us, and we follow that in some of our research and training programs. And I know that you've had very engaged approaches for things like the development of Healthy Chicago 2025 and other initiatives. But it's hard to do that, right? If you don't have the right systems, it's hard to do that quickly. Right. So you're making fast decisions at an executive level with data and better systems, but does that permeate to the local level in a way that that sort of doesn't allow the health equity challenges to fall a step behind? And I guess with that, I wanted to bring Grisel and Jolene into the conversation and invite their reactions just from those two different perspectives, one on data and modeling for decision making at a policy level, and then also community engagement and workforce development that's sustainable. Any comments from either of the two of you?
Thanks, Allison. It's super interesting to hear this like very macro overview of everything that's been going on. I think my question, I have lots of questions, but one primary question I have for you is like, do you feel that like despite all the data, like the data fire hose that came in, that you had the right data that you needed to make the decisions that you had to make?
Yeah, I think broadly we did. I mean, some of this, it was interesting also, of course, for this outbreak to emerge in the political setting that it did, where the CDC, which might have more traditionally been playing a larger role in terms of defining what that data should be and setting perhaps some standards and thinking about that more nationally, did not play as significant a role as they would have in prior outbreaks. So I think, you know, some of the work here was very local, like in terms of what do we need? Like literally, what do we need today? What do we need tomorrow? How do we define what's working and what isn't? And this is to this sort of evaluation point, I think. So where I think about testing kind of as an example of this, initially we were just like, okay, we got to get testing going, right? And it's like, where is there testing? We didn't have a lot of capacity. But then it was about saying, how can we divide this up and say, not just where is there testing, but where do people live? Where are the barriers? And then it became eventually, you know, we really got into a system where it was looking at every testing facility, whether it's an academic center, whether it's a public center, whether it's our own public health testing, and saying sort of how good was that testing? Did we have a high positivity? Did we have a lot of people coming in from outside that zip code? Like, is it useful? Is it not? And then really trying to, you know, to the question of how do you bring communities into this data discussion, setting these tables where every single week we're saying, here's, you know, like, this area of the city is having a problem right now. We need to get testing into this area. We have the opportunity to put mobile testing, you know, in 2 spots this week. Like, tell us where, what should that look like? How should we involve it? What should it be? And really saying, you tell us based on this data, where the resources should be. So I think we have broadly, partly because our healthcare system also, like, you know, I can't emphasize, like, so many of the hospitals were very willing to not just do what needed to be done, but do more than needed to be done in terms of data integration and collaboration. We made some real progress there. You know, these are systems that don't normally talk to each other. And we were worried about, you know, are we gonna have a complete overwhelm of our healthcare system? And the ability to have a systems level view of how many COVID patients are in different spaces, and this sort of cross-system view was something we didn't have, but then worked with partners to grow early on. So I feel like, you know, at some level we've gotten used to the data that we have, but I do think it's been broadly enough, and we've been lucky. I mean, I have to say it, sort of here in Chicago, that our political leaders have been very, you know, have had the goal of where we know the data and where we know the science, really using that to drive decision making, which has also not always been true, I would say, across the country. And so I feel like we've broadly had what we needed, but we haven't always evaluated very well some of the things that we've done to say which of these are things that we want to build on in the future.
I wanted to ask Grisel if she had any comments.
Hi, everybody. So thank you for inviting me to be part of today's panel. Dr. Arwady, thank you so much. Thought that was a helpful overview as well. I think as I listen to you speak, one of the things that I've been gravitating towards is this idea of the pipeline of people in the field of public health. And so from where I'm positioned, I'm thinking about the needs of students, the needs of community partners, and then the needs of the university faculty and the staff. So, you know, I have comments, not questions, and this is more for our audience. I think, you know, the public health workforce has to develop, you know, represent the diversity of the communities living, working, and socializing in the Chicagoland area. And, you know, there have been like historical abuses in research which prevent us from really developing those strong relationships. So Dr. Arwady, you had mentioned so many instances where community engagement and community partnerships are embedded. And I think in academia, we just need to do more to work towards that model. And I think we have a lot of great teams. We're gonna share a resource list at the end of this session so that you can tap into the tools, the resources, and the consultation support that they can provide you. But I think there are many research teams here who need additional support to get started on this journey of community academic partnerships, or to, you know, build from where they're already at to continue to innovate. So I think for university faculty and staff, first and foremost, we have to provide more training regardless of whatever degree you have, whatever position you have, on community engaged pedagogy. This pedagogical approach has models that focus on respect, reciprocity, power sharing. Those are all core principles of community engaged research. And Dr. Arwady had shared plenty of examples, even something as simple as sharing the data back, saying, what do you see here? How can we do better? What are some next steps? I think it's important to build that out more so that people understand that there is a way to work with community partners at all levels of research to get this done, or evaluation, depending on the foci of your projects. For community partners, we've been trying to work through the programs of public health, specifically the MPH program, to provide more low-cost public health educational programming based on the needs that our community partners had shared with us via a community assessment we conducted last year. So we kicked off a revised version of our Community Scholars Program. We have information, again, that we'll send out through Adela. We have a registration that's open that ends on Friday, where we're having an instructional workshop on Data Visualization 101, specifically for community-based organizations and nonprofit organizations that have different types of resources. Our instructor is well-versed in working with these types of organizations, regardless of the resources that you have available. And then we have another instructor who is specifically working on promising practices in community engaged partnerships. So this very topic that we're talking about. And they both come with a wealth of knowledge and experiences, both good and, you know, missteps that have occurred and how they have overcome those missteps. So it's specifically geared towards working professionals. And I encourage folks to check out that information and to continue to give us, you know, any feedback on how we can continue to support the existing public health workforce in ways that make sense for working professionals who oftentimes are caregivers or have other responsibilities outside of their work setting and need this information in a way that makes sense for where they're at in their education. And then the final piece I wanted to just offer up is that our students, you know, the program in public health waived the GRE. This is significant in that it really does help ensure that we're bringing in more diversity in the workforce that we are helping to shape and nurture. It particularly impacts women and people of color. And this year, you know, Dr. Lauren Beach is going to be teaching our first ever course on LGBTQ health, which is exciting. So for students out there, I encourage you to check that course session out. And for our applied practice program, you know, the last 2 years, we've been working with our community engagement committee to change our field experience and augment it. It's now called the Applied Practice Experience Program, where AKA the internship in your public health degree. And we've talked about community asset-based development, we've talked about community engagement, and we're connecting students to public health projects that are currently happening in different community organizations around the city. And I think it's through those measures that we'll start to augment the diversity that we need in our public health practice. The last piece I would say, or profession I should say, the last piece I would say, I am often in these conversations and no one is talking about language access plans. We need to make sure that the public health department projects, all the researchers, academics, any partnership, any project you're doing has a language access plan. Chicago is a very diverse city. English is not the only language that's being spoken. And by providing sufficient resources and support to dedicate that in your project in the front end and working with community partners, you can make sure that they can do quality assurance checks on your translation and interpretation of your materials, as well as they'll help you inform the cultural nuances that is very necessary in order to have a successful project. So I just wanted to point out some ways that we're working on this. I think we can always grow and do better. But I think that Dr. Arwady, you mentioned so many examples. I really wanted to encourage our community to continue to do what you can to examine how you can improve your community engagement activities.
Thank you for that, Grisel. That was really great. And maybe we can talk just a little bit more about this area of public health workforce. And Allison, you gave some really great examples of how the pandemic and the health department's response to the pandemic has allowed you to think about fundamental infrastructure in new ways and to try to develop new systems that would allow us to function more efficiently and more effectively, and not just now, but in the future. With respect to workforce, public health workforce, Grisel just shared a lot of really great information about resources and activities. I'm cognizant that in March, President Biden signed into law the American Rescue Plan Act of 2021, which has a significant investment in it in workforce development. And a lot of the description about that sounds like community health worker type of activities around a workforce that would be at the ready for testing and for vaccine deployment, contact tracing, and activities that related to the pandemic. It would be a shame if that wasn't an opportunity to build a sustainable form of a new public health career, and that those individuals have the develop the competencies. I think you were describing before, sort of bringing people in as health workers, but them developing core competencies that allow them to function in other ways as sustainable members of the public health workforce. We're interested in the training side of that really actively, and even partnering in formal or informal ways with the public health department in trying to make that happen. So I wonder if you can comment a little bit about your perspective on how these new monies might trickle to the state or city level, what sort of opportunities there might be through some funding that came about because of COVID, but really allows us to build and address some prevailing deficiencies in the workforce on the public health side.
Yeah, absolutely. I think it's such an important question. One thing I will say, we of course looked with pleasure on the American Rescue Plan and some of that language, as well as some of the funding that is dedicated to public health. I will tell you, we have not yet heard any details. So we have not yet heard how any of that is going to translate into funding at the local or the state level. We have certainly been involved in some of those conversations at the federal level around what some of what we see needs to be, and trying to really emphasize a couple of things. One is this need for sustainability. My biggest concern when we are hiring people is this a job that's going to last, right? Like most of the hiring that the health department itself is doing right now is on COVID grants that, have 2 years on them. And you are going to get different people who are interested in a job that may go away in 2 years. And you're probably going to get people who maybe have different options. And, this thought of maybe I wouldn't have a job in 2, like even that itself, I think can be a significant barrier in terms of who might be interested in taking a job, even if they're interesting, if you can't guarantee that it's sustainable. And so we've really, for me, anything related to kind of hiring workforce is about, can we make sure there is a way that when we are bringing in folks and investing in them, it can be something that is as sustainable as it can be? And it's not what people always tend to think about. There's a lot of like, let's get this money, but if it's a one-time bolus, you might be able to train some folks, but then, are they really going to be able to get in there? And so that's part of why we felt like a year ago, the ability to, we submitted to the federal government before there had been a lot of thought about this. Here's what our plan is in terms of hiring people right now, in our hardest hit. We already knew what the hardest hit communities were and were going to be. And we actually did not hire them as CDPH. We actually felt like that was important. We wanted to instead, we funded through the Chicago Cook Workforce Partnership, which is already set up to really support people coming into the workforce and developing through the workforce, and have a lot of are a good umbrella organization. But then we worked instead with existing community-based organizations to then hire people or have some of their own staff do this kind of work. Because where I think about the ability to sort of sustain, I want to build, it worries me to bring in hundreds of people to the health department and then think in 2 years that there isn't going to be anywhere for them to go. And so we've been pushing a lot on sustainability. The other thing is, emphasizing that, we're all about community health workers. Obviously, we think that there's an important role there, and certainly, opportunity for more conversation around training and support and growing people. And what does this actually look like? People use the term CHW to mean a whole range of things. And there's been a big conversation about what does that training look like? Is there certification, et cetera? But also setting that aside, that we don't, there was some interesting language in there about sort of this idea that maybe, kind of like AmeriCorps, you would sort of do public health for a year, you would do it for 2 years. And we felt very strongly that it was important to kind of put our stake in the ground that public health is a career, and that it is something that we want to also make sure that we set the bars low in terms of bringing people in, but that it's something that we want people ideally coming into and being, like I am, like there's nothing that I want to do except public health, and having pathways for people to grow and be sustained there. And so we pushed for honestly, for some more support around things like administrative positions in public health, which is not what people are thinking about when they're thinking about what do they want to be funding. And so I think how you bring folks in, how you then continue to train them has been a point that I think CDPH has not done a very good job at over the years. We don't get a lot of funding for that traditionally. And you can see skills sort of stagnate, in terms where we think about partnership. I love this conversation about what does that look like for public health professionals. And then maybe just the last thing off something Grizel had said, this idea of language, like how critical that is. We have, we did some surveying, and I forget, we have something like 140 languages that like people at the health department speak, right? And really recognizing this skill as something that is worth its weight in gold, where you're thinking about doing this kind of work with potentially, immigrant and refugee and communities, and how do we lift that up, not just sort of as a nice to have, but like really as something that is a skill that makes somebody, in my mind, sort of extra valuable. And I'd like to actually value that within hiring and admissions, or, whatever the case may be. At the United Center, we've done about 250,000 vaccinations. 46,000 of those people needed some sort of language, right? Like translation intervention. And, we've set up the systems to do that and to make sure that it was central. And this is, I think, again, a thing that has come much more to, like, we always would like translate the website, you know how there's the difference between like, we're sort of checking the boxes versus we're being really serious about this. Like, I don't speak now without somebody then coming and translating my remarks in Spanish right after me. Like we've thought really differently about what that means. And I think in a large city or in any space where you've got a highly multilingual population, really recognizing that as a skill to sort of call out and lift up and think about people who have that language and that that cultural knowledge as something to kind of highlight and grow has been something else to really work on. And I think it fits into this workforce piece.
So there's another sort of thread that I'm picking up on here, and it is, you mentioned several times a number of activities that sort of happened very quickly based on, in many ways, collaborative decision-making around reading the data that was available at the time. Some of those decisions we found out later maybe weren't necessary, or the data led us in a slightly wrong direction. Maybe the McCormick example, there was a comment in the Q&A, is a good one, where we accomplished something really remarkable by bringing that up very quickly, but was it all necessary? Was that, could those efforts have been placed somewhere else? And it's in the rearview mirror, it's easy to question things like that. But the point I'm trying to make is just policy decisions. There's this conflict between making decisions quickly with the data that are available, and sometimes you've got experts and data and models that predict potential future outcomes, and they're not in agreement. And you have to make difficult decisions from the conflicting sources of information. And then after that decision, you have to have a system in place to evaluate what's happening, so that as early as possible, you can determine whether that was a wise use of limited resources, or whether people's time and energy and other resources should be spent in other directions. I want to open this up a bit just to Jolene as well, and just, I know she's at the table with other modelers. I know that the health departments and the governor's office and others, like, they're sort of talking to different groups, and sometimes those groups don't agree. How do you have systems in place that balance, I guess, the limits to data and evaluation when it's really so critical? And how do you ensure that the right evaluation systems are in place, so that when there is uncertainty, you can be smart about identifying it and shifting course as quickly as possible?
Do you want me to start on that, and then Jaylene come in?
Yeah.
So just quickly on the McCormick comment. So actually, before the McCormick comment, one thing, my job as a leader, I feel like, is actually first and foremost to support my team. And that is not always the part people think about. They think about the public facing, the explanation, et cetera. But, I've got hundreds of people who have just been working around the clock, for more than a year. And something that I am really committed to, and that I often remind my folks of, is that we always have to make the decision based on the best information that we have at that time. Make that decision, commit to it, talk to others, make sure it's sort of an informed decision, make that decision, own that decision, and move on from there. Because I think there's the possibility to sort of get stuck in this, like, looking back, or kind of where, I've said to my staff so many times this year, because they worry, right? They start something and maybe, and I'm like, no, like, as long as you are making decisions on data and you're informing people, there isn't a decision that you can make that I am ever going to really call you out on, like that you shouldn't have done this, or I'm going to embarrass you, And I think having sort of this strong team culture is as much about that when we make a decision, like, we own it. Like, no matter what happens with it, it's something that we own. We can explain why we made that decision. And the McCormick one is actually, to be honest, I would make that decision right over again right now, because at that time, the most worried I was at any point in this entire COVID pandemic was right around that moment when we had seen the healthcare system get overwhelmed in Italy. We had seen it getting overwhelmed in New York City. And recognizing that we were on this trajectory that, thank God, I think some of when, into the modeling point, when the decisions came in to do some of these really dramatic lockdowns so fast, we did manage to sort of just skirt that. But that was not a foregone conclusion. And I 100% would make that decision again every single time. And I think, you know, it's not this question of like, would you go back? You know, what could you have done with those resources? It's about making that decision with the resources you have. And in this case, you know, that it was federal resources, recognizing this was a need, make sure it's in place and then kind of move ahead. And so I just generally, I think that's always just something I feel pretty strongly about. And, you know, I don't always make the right decision, but I do try to own the decision that I make and say, you know, would have done that differently, but kind of not in that example. So.
I would just like to, I'm sorry. I just wanted to add that that is a strength too, when you have a community academic partnership, that you have people around the table, they're grappling with the decisions with you. They are also, you know, part of the buy-in around the next steps. And then when things don't go as planned or perfect, that there's an understanding that they can also support you in messaging that out, because too often we are held back by the perfect solution, and we all know there isn't a perfect solution. We just have to take, you know, stepwise approaches to moving forward. And I think that's a strength as well about having community academic partnerships, is just helping others understand what you had to, the decisions you had to make based on the information you had at the moment. Jaylene, please.
I have some thoughts on Ron, what you said, that like, could modeling be brought in as like an evaluation tool like later on? It is something that sometimes models are used for, like modeling counterfactuals, like what if we hadn't done this? What if we, you know, had chosen to do that instead? But I think there, even though in many ways that sounds like an attractive and wonderful use of models, it's not always a great idea, especially because there is such a diversity in model, I think, type, quality, suitability to the question. And I think if you're going to try to put like a quantitative estimate on like, if we hadn't done this, how many more lives have been saved, or how many, you know, lives would have been lost, then you need to have a model that is very, very grounded in the actual real situation that you are asking this question of. So if I were to, you know, ask this question of Chicago, then I would want to be very confident that I had really captured the true situation that had been happening in Chicago. And that's going to require, first of all, like probably lots of data, data that, you know, I understand what it is and what it isn't. And so that usually involves like a very close relationship with people who went out and gathered that data, often the public health department. And if that relationship isn't there, and there's no like iterative process where the modeler is like, well, I tried this, and the public health person is like, that was stupid, that's not how it works, and then you change it and then you update it. If there isn't that kind of exchange and close relationship, then often the model that you build is like wrong in like, you know, some big ways, many small ways, and then the numbers that come out are ultimately somewhat meaningless. So I think, you know, I think it is possible. I don't know that it's possible with the data that has been collected to date to look back over 2020 and be like, well, what if we had, you know, halted going to phase 2 or 3 or whatever, or tier 7. I don't even know, like this whole collection of phases and tiers is still very confusing even to me. But so, you know, and so I think the use of models kind of in a kind of a more live pandemic situation is more to give a qualitative feel for like what could happen if you're going to try, like, if you're going to sample from a collection of different strategies. So like, well, what if, like, you know, the B117 variant like expanded like this quickly, or maybe it expanded more slowly, or if we like vaccinated at this rate versus that rate, like what are the different trade-offs, like which one is stronger? And that's really, I think, the kind of more qualitative strengths of this kind of like dynamic modeling. And like, again, like I would be very hesitant to use it to do evaluation and progress reports and stuff like that, simply because we don't have the level of detail of data and understanding that I think is necessary to do a good job.
Yeah, I think, it's interesting. I think one of the ways that the modeling has been most useful for us, and, it's been great to see this community sort of come together and trade information. We've worked a lot, especially with Argonne National Labs, that have this city, sort of a city agent-based model that had already been set up to kind of look at infectious diseases and had quite a lot of granularity in terms of how people move across Chicago and where they go. And so the ability to kind of think about, if you close a school, like what does that do in terms of how the agents may move? And, so this very, very granular, really practical, where we were thinking about things like, shutting things down, the ability to kind of, with at least some guess, what might that look like? But the other thing for me was that trying to sort out how much are people moving, like more than they were, like because so much of it, it's like how much is sort of what the government is doing in terms of closing things versus how much that individual, what are people doing in their home, the agent moving, et cetera, and recognizing that it's this individual, they go together, but how much people sort of take this to heart and follow the public health guidance is really the most important piece. And so how do you then take the model and turn it into kind of your communication strategy? And then we were behind the scenes looking at how were people moving in Chicago, right? Like some of this anonymous cell phone data, and like you could actually sort of see week to week, where in Chicago could people stay home? Where could they not? How did that fit in? And so it was pulling together like these different ways of sort of trying to look ahead and predict. And, to your point, sometimes it's really high, so, but it's less about like what the number is and where you're getting, and more like which of these interventions do we think is likely to impact the most? And for me, I was always interested in how do you use that to develop kind of your communication strategy?
Yeah, and I don't want to belabor this too much more, but I guess I was also thinking on the side of other forms of academic public health partnerships for evaluation purposes. And, if you, for example, use a very engaged approach to identify that, to address the vaccine take-up inequities, that you could use strategy A, B, or C, and they all might be effective, they all might be acceptable in the community. And you say, well, we can't do them all at once. We're going to choose A first, then we're going to do B, then we're going to do C. And you might wonder whether that's the right sequence or the right choice or the right level of investment. And there are ways to design, step wedge experiments or, sort of sequential rollouts that aren't really modeling, but are a way to evaluate in real time whether those policy decisions, which have real resource implications and effectiveness implications, whether they're wise, whether they need to be refined. And I wonder if that's another area for deeper collaboration.
Yeah, totally agree on that. I think, that's because we've been shifting tactics so much and sort of trying things and trying other things. Even right now, we are experimenting with door-to-door vaccination efforts, and we're trying things like going and knocking on all of the doors first 2 days in advance. Is that better than when you go and say the vaccine bus is right here now? Do you want to, like, who should be doing that? What kind of language? Like there's a lot of these, like, it sort of is a little bit of, it's not a trial, but it's like we're trying it in these different ways, and we're trying it over here in this way and over here in this way, and then we're sort of gestalting what seems like it works. But then, we're going to make big decisions. I mean, we want to knock on like every door in our 13 least vaccinated zip codes like soon. And so it's this mix of, I do think there's a lot of role for expertise in this sort of kind of the implementation and then kind of the evaluation piece of it, which has implications not just for Chicago, but how to do this better for whatever the next thing is that happens, that I think is a really clear place for additional collaboration. And we'd love like, support on that. The behavioral health piece is or like some of these incentives and the sort of what drives kind of behavior and decisions and how does that fit in. That's another piece where we know folks, in public health have a lot of expertise and ideas. And, I think it's just, we're moving so fast that you want to have these relationships sort of set up in advance so that it's not like we're saying, okay, we want to do this, it's sort of like the people who are helping to influence them are the ones who are kind of already in that conversation. And so we want to set these up early so that when we're like, all right, this is what we want to do, especially if it's not a pandemic, and you actually have a month or 2 or 3 to kind of plan what this should look like, would really, really love to make sure we're doing that in the sort of most up-to-date strategic way. And I think a lot of, academic partners could really, really help with that.
Dr. Arwady, I have a question for you. The spaces that I'm in, there are conversations about just a lack of clarity around vaccine dissemination plans and, long distance travel to get to their spots. Conversations related to folks not getting a second dosage. And then new has been, what about my children or my child? Should I get them vaccinated or signed up for a research study? And if I was interested, how would I do either of those things? So I'm just curious, what can we be doing together as an entire community to build more information and transparency around those 3 efforts, obviously allowing people to make their own decisions?
Yeah, absolutely. So I think an example of something that has been critical to success and that we launched a little later than we should have, like to the point of what do you need, where do you need to go? Our call center has been critical, right? Recognizing there's a lot of people who don't have the tech and are never going to, do all this, et cetera. And so, 312-746-4835, that is our number in the city of Chicago. There's about 200 people who are these community-based, these folks who we hired a year ago to start with contact tracing, who have now really, many of them moved into the role of vaccine ambassador. There's 200 people sitting there doing nothing but like talking to folks and saying, let's get a vaccine to you. So we will be through our homebound program like this month in the next couple of weeks. If you know people who can't leave their home, like we've brought vaccine to, more than 1,000 homes already. We've gone to senior centers, et cetera. But increasingly, it's going to be about, it's only been about a week and a half or 2 weeks that we actually have enough vaccine, right? Like to this point, there's been this feast or famine and the Hunger Games, and you're fighting it. We now, for the first time, honestly, and this is part of why, from my standpoint, we're able to move more quickly with reopening, there is adequate vaccine. Every provider who wants vaccine can have as much vaccine as they want, right? Like we have walk-ins at all of the city sites. The pharmacies are kind of turning into walk-in, like we've been working to lower barriers. But it's about letting folks know what those resources are. And I think for so many months, because we were trying to have this equity focus, we needed to, like, one of our biggest problems was that you'd set up an event or, an outreach, a vaccination clinic that is meant for people in Englewood or meant for people in Little Village or Austin or whatever. And if you didn't keep that close, you had hundreds of people driving in from, Schaumburg or whatever. And like this work of sort of, for months, we've needed to kind of keep some of our work like closer to community to keep those resources for those community. And just in the last week and a half, we've had a total flip. So I'm like, you want to come to Kennedy King? Like, we're open. Anybody, come on down to Kennedy King, right? Come to Chicago State, like come to Apostolic Faith Church, come to, any of the city colleges, come to the providers, come to the pharmacies. Like, there are hundreds of places across Chicago to get vaccine, and every day more of them are open to the public. And so, ZocDoc.com/vaccine is our sort of online where you can make an appointment. If you go right now, you'll find 15 places where you can get an appointment today or tomorrow. But now you can walk up and you can call that number, and we help people. Do they need transportation? Like, what else do they need? This work of not just the vaccine, but what are the other barriers to get it in place? I think for kids, it's going to be really essential that kids get vaccinated. I'm expecting next week that I think it's likely, based on the early data that we've seen, that the FDA and then the CDC through the Advisory Committee on Immunization Practices will give that authorization for the 12 to 15-year-olds. And we're really excited about that. We've been planning for a long time because we think it's an opportunity to vaccinate families as well, not just the kids. And recognizing that the older kids are more likely to transmit or have, compared to the youngest kids. But it's, and I would refer people when the data comes out if you're interested, but the safety data looks fantastic. The efficacy data looks really good. The antibody levels in the kids was actually higher than it was in the young adults in terms of that protection level. No concerns for, serious outcomes, and really the data looks fantastic. So I'm very excited about this availability opening up. We're already planning, there's going to be some of these vaccine bus events already at some of the CPS high schools, and sort of more of that to come. We're going to be opening up, when available, all of our city pods to children. We're working with pharmacies to make sure that they can do it. We're working with providers. It's only Pfizer, which is the harder vaccine in terms of the operations, but we're doing what we can to support on that. I think it is going to be this next push. And so I would really, really encourage people, get your kids vaccinated. Again, it's the most important thing to protect them, but then also think about, is there a grandma, a great grandma, an aunt, somebody else who hasn't been vaccinated, because we're still lagging in 65 plus coverage too.
So we've got about 10 minutes left. I think we'll probably close up a little bit before the bottom of the hour. So let's take about 8 minutes. I thought I would just invite you all to make any brief closing remarks. I will say there's a couple of lingering questions that we didn't get to in the chat. One has to do really with, it relates to your questions earlier, Allison, about how COVID, a response to COVID, or your department's response to COVID, has allowed us to think about putting systems in place that will help you address other Healthy Chicago 2025 priorities. And the question was specific to gun violence. There's also a question about, sort of the tea leaves being that there's going to be progressive reopening and back to school, and that has some people concerned. Are we moving too quickly? Will that be a mistake? What concerns? So I'll just mention those before you make your comments, but if you want to address those, go for it. If you have other thoughts you want to share, please do so. Why don't we start with Jolene and Griselle, and then we'll finish up with Allison. Do you guys want to add anything before the close?
Sure. I guess I think one of the things that's been most striking to me is the disparities angle. And Allison, you alluded to this at the beginning, that there is only one map of Chicago, and no one was surprised really that this is kind of what happened. But I ask myself, for the next pandemic, how do we make sure that we don't once again achieve the same map of Chicago? Given that we know where the vulnerable communities are, who the vulnerable people are. Now that we have some opportunity for hindsight, what should we do earlier, better next time that would prevent some of those very, very striking disparities?
Griselle, do you want to share your comments, and then we'll turn it to Allison and let her finish?
Sure, thank you. So thank you again for this opportunity to speak. I would say that I would just reinforce respecting the knowledge and expertise that community partners bring is really critical. I think it's important to start nurturing relationships with community partners today. As was said earlier, you have to start today in order to have an impact later. This is a relationship for the long haul. And we can't obviously be all things for all people, but when we partner up with different community partners, we can understand different lived experiences and make sure that we are centering voices that are, typically either vulnerable or not centered because they don't reflect the dominant communities in this particular society. And I think that's critical for us in public health, because we have these existing inequities. They were in place before the pandemic. They will continue to be in place after the pandemic. We have to build a diverse public health workforce, and diversity goes beyond just race and ethnicity. And I think that brings such a powerful approach to anything and everything that we do. And for folks who haven't done this work, this is where I think community engaged pedagogy is really important. There are theories, there are models, and as I shared in the chat box, there are different teams who are providing resources and support and are available to help you start. Or if you're already doing this, to help you take your game to the next level. So that's what I would encourage folks, keep having those conversations. Thank you.
So first, thanks so much, Ron, Jaylene, Grizel. Really appreciate the conversation and the interesting questions. And thanks for everybody who's tuned in and put questions in, and to IPHAM really for hosting this conversation and, continuing to really be such an important voice in this space. And as we work to really use this platform that public health has right now. And to the question about, what comes next and how do we think about gun violence? I think so much of this is about recognizing that there is this window right now where people are interested in public health, right? A year ago, or a year and a half ago, most people probably thought public health was medical care for poor people, right? And the recognition that public health, right? What is it that we do? How is it that we think differently than clinical medicine? And how do we think about all of these root causes? Certainly access to medical care is a piece, but we all know the larger drivers of what makes a city healthy is about the decisions that we make as a society, about where resources go and how do we support communities, and what do these underlying issues of housing and education and food access and community safety, what do all of these look like, and what are the decisions that we make that set us up for this? And so quickly on the reopening question, I feel good about where we are broadly related to reopening. The schools data has been one of the strongest data sources throughout this entire pandemic in terms of, we make a lot of really difficult decisions, but the decision around advocating for children to be able to return to in-person school with the appropriate mitigations was, from a data perspective, one of the easiest decisions that I and we had to make. But then I think politically, it was one of the most, and continues to be one of the most difficult ones, because there is a lot of fear, which I completely understand, and a lot of wanting to make sure that schools are resourced appropriately, and that systems are in place. But I am certainly looking to see good vaccine uptake in those adolescents and then later in the kids. But we've certainly had wide availability. School staff were an early priority for us in phase 1B when vaccine was very limited. I think to tie this a little bit actually to the gun violence piece, we have seen so many indirect impacts of COVID, and all over this country, gun violence is surging. And I think there's still a lot of questions about how this all fits together. That's part of a much larger conversation. But I do think, to an extent where we've lost a lot of the more traditional support mechanisms for adolescents, a lot of which have traditionally come through schools. I think we've seen, I'm not saying that that's the source of the violence per se, but I think we've disrupted a lot of support structures that have for years helped make sure children in Chicago, are getting sometimes basic needs met, but also mentorship and growth, and sort of what does all of this look like? And so for me, really supporting education has always been a piece of public health, but I think as we think about post-COVID, it becomes even more so. And where it's where do we go from here? And how do we take some of this to think about the inequities? Again, that Healthy Chicago 2025 plan, let me just take you back to the fact that we didn't have to change a word of this post-COVID. If anything, our racial and ethnic, life disparities, life expectancy disparities have widened with COVID, right, across the country. And we have seen, honestly, with this vaccine outreach and work, that it is doable to somewhat change this map. Right? So our 15 highest COVID vulnerability index communities, the ones where we did Protect Chicago Plus, et cetera, at the beginning of the pandemic, we ranked all 77 community areas. Again, this is based on all these underlying root causes, and there's high vulnerability communities, there's medium vulnerability communities, and there's low vulnerability communities. And Chicago, you can guess what some of that geography looked like. Well, let me tell you, when we started vaccination, it looked just like you would expect, right? The low vulnerability index communities were getting vaccinated way up here, followed by medium, followed by low. With very concerted effort, we have higher vaccination rates now in our most vulnerable communities. They are actually outpacing that medium vulnerability. But the problem is, from a resource perspective, we were able to kind of invest, right, initially, mostly in those highest need communities. And what we saw was that in those 15 communities, about half of them are now, they're not in the highest need communities in terms of vaccine, but then other ones have moved in, and they were ones that in a lot of cases did not have as much of the support around, I think, a lot of these community-based groups and a lot of the pre-existing tables and advocacy and people working together. And so for me, where it's like, where do we go from here? This work of building and sustaining community partners and clinical partners, pairing them up, the health department not getting in the way of that decision making, but setting a framework to try to make sure we're rowing together, and then using funding in ways that is not apologetic about the fact that there are some parts of the city that need more funding than others, and working to hire people from some of those communities. So gun-related homicide is number 2 in Healthy Chicago. It is the second driver of the Black-white life expectancy gap. So I refer you to that if you'd like to see some more information about some of what we're thinking about. And if any of you, are working on issues related to this, we'd love to have you be part of this. As we come out of COVID, it's not going away, but we are very much trying to take these lessons and apply them to some of the other priorities of Healthy Chicago 2025, and would love more academic partners in this space. Thanks again.
Well, I'm sure with that you'll get a lot of connections. We had great audience participation and a lot of interest today. So I want to thank all of you for taking your time to participate, particularly you, Dr. Arwady, who has a very packed agenda to share an hour and a half with us. I'm inspired by the discussion and the opportunities I think that there are for us to deepen our Northwestern CDPH academic public health partnership in a variety of new ways. So as we talked about before the call, I look forward to syncing up with you and engaging with you and your staff about along with Chriselle and Jeline and others around how to actually make those things happen. So thank you so much today, all of you, and thank you to our audience for a successful Population Health Forum. Have a great day, and best wishes to all of you, and thank you for another successful Population Health Forum.
Thank you, everyone. Don't hesitate to reach out.